I'll start off with some statistics. So COPD is one of the top three causes of death worldwide, and 90% of the deaths in middle and low socioeconomic countries, and the numbers tend to increase in the coming years. So that's what. So that's why COPD is one of the most deadlier diseases. It accounts for about 90% of the deaths in middle and low socioeconomic countries, and the numbers tend to increase in the coming years. So the definition of COPD. So this is the globally accepted definitions of COPD. Your books might give different definitions as such, but this is what is given by the GOLD. So according to the GOLD guideline of 2022, chronic obstructive pulmonary disease, it's a common, preventable and treatable disease, and it's characterized by persistent respiratory symptoms and airflow limitation. And this is caused due to airway or alveolar abnormalities, which in turn is caused by significant exposure to noxious particles or gases. So the definition, although it is a big definition and it seems complicated, like we did in asthma, we'll divide the definition into three parts. So the first thing is it's a common, preventable and treatable disease. So that will be a first part of the definition. Second is basically discusses the pathogenesis of the disease. That is, there will be and the symptoms. So there is a persistent respiratory symptoms and airflow limitation. The important point to note here is when we discuss bronchial asthma, one of the main, if you recollect, the main one of the main terms which was used in definition was the symptoms of cough, breathlessness, and wheeze, and chest tightness, which vary over time and intensity. So it is not something that is persistent. The symptoms will come on and off whenever you have an exacerbation, like whenever you have an infection. So during those times, the symptoms of asthma will get exacerbated. But COPD is a chronic disease. Therefore, it has persistent respiratory symptoms and airflow limitation. And the third part, now what is the pathogenesis or what causes this airflow limitation? So it is mainly due to airway abnormalities as well as alveolar abnormalities, and it is caused by significant exposure to noxious particles or gases. So remember the three things: common, preventable and treatable disease, persistent respiratory symptoms and airflow limitations, and it's caused due to airway or alveolar abnormalities, which is caused by significant exposure to noxious particles or gases. So this is one of the charts which is given in gold. Now, etiology, as we all know, the most common etiology of COPD is smoking and pollutants. And there are host factors as well, which I'll be discussing later. There might be genetic factors which are involved in all this. Now, all these host factors and genetic factors, it contributes to impaired lung growth and accelerated decline in lung function, lung injury, and lung and systemic inflammation. So all these things will in turn result in a small airway, persistent airflow limitation, leads to emphysema and systemic effects. So basically, your smoking and all those factors results in a persistent airflow limitation, and in turn, it causes an accelerated decline in your lung health. It causes systemic inflammation, and the clinical manifestations occur. So what are the disease development and prognosis? Now, what are the factors which contribute to COPD? The most common cause is cigarette smoking and tobacco use, genetic factors, and air pollution. And earlier, it was more of a cigarette smoking and tobacco use, which was the most common cause of COPD. But now, over the years, especially in our country with poor air quality indices, air pollution has been a main contributory factors to COPD. That is, mostly in non-smoking individuals, air pollution has been a major factor which has resulted in COPD occurring in non-smoking individuals. So according to Harrison, these are the three entities which are present in COPD. One is chronic bronchitis, second is emphysema, and the small airway disease called as bronchiolitis. So, and in some cases, bronchiectasis has also been referred to as a part of COPD, but COPD is more of a chronic bronchitis and emphysema phenotype. Now, coming to the first part, what is chronic bronchitis? So, chronic bronchitis is more of a clinical entity. It is defined as cough with sputum expectoration for at least 3 months and a year, during a period of 2 consecutive years. So in this, the patient will not be symptomatic throughout the year, like in COPD. Here, the patient will have cough with sputum expectoration for at least 3 months in a 2-year period. That is, 2 consecutive years, he'll have symptoms for 3 months. And chronic bronchitis, so as we know, in case of bronchial asthma, in which there is a bronchial hyperresponsiveness and there is a bronchial thickening which is occurring, or a bronchial or the smooth muscle hypertrophy which is occurring. In chronic bronchitis, associated with hypertrophy of the mucus plugging glands, which is found in the submucosa of the large cartilaginous airways. Now, so that is chronic bronchitis. So this is important, the definition of chronic bronchitis, which is defined as clinically as cough with sputum expectoration for at least 3 months a year during a period of 2 consecutive years. Now, next we are coming to what is the definition of emphysema. So this is which is most important. Emphysema is defined as pathologically, it's an abnormal and permanent dilatation of the airways or the enlargement of airways. And where does it occur? It occurs distal to the terminal bronchioles. It's accompanied by destruction of the alveolar walls and without any obvious fibrosis. So this without any obvious fibrosis is a very important term which has to be taken in mind while discussing a definition of emphysema. And the part of the lung involved, which is most important MCQ in emphysema, is the sinus. So there are different. So just remember the definition of emphysema. It's a permanent dilatation or enlargement of the airways distal to the terminal bronchioles, accompanied by destruction of the alveolar walls and without any obvious fibrosis. And the part of the lung which is involved in emphysema is always the acinus. So what are the different types? I'll be showing the diagrams in the next picture. So what are the different types of emphysema? As we know, one is centriacinar emphysema. And this centriacinar emphysema is more common in smokers. Remember, it is C and S. And it's more of an upper lobe predominant emphysema. Pan-acinar or proximal acinar, it's seen in alpha-1 antitrypsin deficiency. Paraseptal or distal acinar, and parasicatricial, which is an irregular emphysema. That is, there is patchy involvement of the area distal to the terminal bronchiole or the acinus. So this is what is there. So here what you have is, this is the what you called as the structure of the acinus which is there. So here you have the terminal bronchiole, and from the terminal bronchiole you have the respiratory bronchiole, and here what is as a C is the, and these are the various types of emphysema which has been described. So as we know, from terminal bronchiole we go into the respiratory bronchiole, and from there we go into the alveolar and the acinus. So centriacinar means the central part of the acinus is affected. Paraseptal means the distal part of the acinus is affected, that is B. Pan-acinar means the entire part of the acina is or a distal or a pan-lobular, that's the entire lobule is affected. Or irregular or cicatricial is another type of emphysema. So this is a complicated picture in which, because the dashed lines which are shown here, this marks the edge of the acinus. So I'll show you easier diagram. So this is an easier diagram to remember the different types of emphysema. So this is the normal acinus. This is the structure of the normal acinus which is there. So here you have the terminal bronchiole. After the terminal bronchiole, your next part is the respiratory bronchiole, and all these will lead into the alveoli. From here you have the alveolar ducts and the alveoli, and here you have the interlobular septum which is there. So as the name suggests, in centrilobular emphysema, the central part is affected. That is the respiratory bronchiole. So always keep in mind this diagram, because this is something which can be easily recreated in your exam papers. So in centrilobular emphysema, which is more common in smokers and which is an upper lobe predominant emphysema, here you have more of the respiratory bronchiole. The central part is affected. Then I told something called as paraseptal emphysema. In paraseptal, the alveolar ducts and the alveolar are affected. That is more towards the distal part. And then is the irregular emphysema, in which there is the a patchy involvement. That here you see some alveolar ducts are involved, some part of respiratory bronchioles are involved, some part of the septum is involved. So as I told, centriacinar emphysema, here you see the central part of the lobule, upper lobe predominant and more common in smoker. Pan-acinar, that is proximal acinar, which is more common in alpha-1 antitrypsin deficiency. Then you have the paraseptal emphysema, which is the distal acinar emphysema, that is seen more towards the periphery, towards the alveolar ducts and the alveoli. And then you have the irregular emphysema or the cicatricial emphysema, paracicatricial emphysema, in which there's an irregular and patchy involvement of emphysema of the acinus. So, what are the risk factors which leads to COPD? As I earlier told, cigarette smoking is the most common cause. Smoking, indoor air pollution, which has been up and coming as one of the risk factors of COPD. And even in smoking, there's something called as a passive smoking. Passive smoking is it's not the smoker who is getting affected. Basically, the person who stays under the same roof or the same room with the person who is smoking. So that produces some amount of symptoms in that, because in the close contact of the person who is living under the same roof. So passive smoking has been an up and coming risk factor for COPD. Occupational exposure, that is occupational exposure to toxic inhalation, inhalational dust and everything. As I already told in the definition, there's a persistent airflow demolition which is caused due to alveolar abnormalities, which can occur due to organic dust inhalation or other trauma. Then the low socioeconomic status because of overcrowding, and as we know, low socioeconomic status are more common into tobacco chewing and other habits because of the lack of knowledge about the what it can lead to. And host-based genetic, that is alpha-1 antitrypsin deficiency and airway hyperreactivity. This is a gray area because it's more seen in asthma as well, in which there's an airway hyper-responsiveness which occurs. So now we'll discuss some of the risk factors. Smoking, most important contributory risk factors of smoking. Then there's something called as the smoking index, as you all know. It's something for you to find out what the smoking index is. Then next is pack years of smoking, another definition. So whenever you are presenting a case, always in your personal history, if you are saying that the patient is a smoker, just describe it in pack years of smoking. That is, if a person smokes one pack of cigarette for every day for 20 years, that's 20 pack years of smoking. So the number of packs of cigarette smoke divided by 20 will give you the pack years of smoking. Then smoking index is number of smoking, the number of cigarettes smoked per day into number of years. So, and the degree of, so basically what happens is there's something called as FEV1, right? That what which I had discussed in the bronchial asthma class, that is forced expiratory volume in the first second. So the degree of FEV1 deterioration contributes to the amount of smoking. The more the smoking, there's a more chance of deterioration of FEV1. So this is a easy one of the, it's called as a Fletcher-Pato curve. So this curve describes what effect smoking has on lungs. So here you have the on x-axis, on the y-axis you have the FEV1, and in the age, in the x-axis you have age. So now here you see the red line here. In red line, what happens is the patient is smoking regularly and susceptibility to its effect. He has never stopped smoking, he has continued smoking. So he has a what do you say, a downward trend or a fall in his FEV1 over the years, because he has not stopped smoking. And by, if you say take an average of around 65 to 70, he has resulted in death. By around 50 to 55, around 56, 57 years, he has disability and he has resulted in death. Now here you have someone who in the yellow graph, who has stopped smoking at the age of 65. So that means his disability has occurred at 65, but when his disability has occurred, he has stopped smoking. So that has expanded his lifespan a bit. So he has crossed 75 years of age. So here, and if you see someone who has stopped at 45 years, he has more lifespan. He doesn't progress to death at around 75 to 80. And someone who has never smoked or susceptible to smoke, this is the normal fall in FEV1. As age increases, there's usually a normal fall in FEV1 occurs, especially when you cross an age of 45 to 50 years. But in smokers, the decline in the rate of decline in FEV1 is pretty rapid compared to the rate of decline in FEV1 in non-smokers. So that is why, and even in a smoker, someone who has stopped age at 45 years, he has a more he has a better lifespan. And someone who has smoked as a 65, he too has a better lifespan than someone who has never stopped smoking. He's in some amount of disability, but his progression time to death has been increased. But if you don't stop smoking, your FEV1 declines rapidly, or it follows the normal curve, and it ultimately leads to death. So always remember, if someone asks you the relationship between smoking and COPD, always describe it in terms of the Fletcher-Pato curve. That is in small non-smokers, how the decline of FEV1 is, and in smokers, how the decline in FEV1 is. Now, environmental tobacco smoke. In this, there is something called a second-hand smoke. Second-hand smoke is a smoke whenever you are taking a cigarette, the smoke, whatever falls from the cigarette downwards, or whatever is coming out from the cigarette, and the people, more of the passive smoking, whoever is there with you, or whoever is living under the same roof, whatever he or she develops, it's the effects due to second-hand smoke. And prenatal exposure, that is during if the mother smokes, there is a high chance of the child, the infant having a more chance of a weaker lung, which in turn may contribute towards COPD at a later age. Then indoor air pollution, as we all know, is a rising risk factor. Occupational exposure to toxic dust, low socioeconomic status, childhood respiratory infection. What does childhood respiratory infections occur? Contribute? As we know, there is some viruses like respiratory syncytial virus, which causes bronchiolitis. So bronchiolitis is also a part of obstructive airway disease. Therefore, whenever you have a recurrent childhood respiratory infection, there's a more chance of his lung becoming weak. And as we know, according to newer guidelines of COPD, even a weak lung, which is caused due to a, what do you say, something recurrent childhood infection or a developmental anomaly, can in turn result in COPD. Then HIV. There are studies which causes show that people in HIV, especially with those with high viral load and low CD4 count, have it's shown instances of having COPD and be more susceptible to developing COPD. Studies are still underway to show to understand the correlation between both of this. Some studies have shown that is it the pneumocystis is carrying pneumonia may contribute to COPD which is occurring. And another important factor is HIV causes activation of alveolar macrophages, and as we all know, alveolar macrophages, but the activated macrophages, is the most contributing factor in COPD because it causes the free radical damages, neutrophil activation, and other things which I'll be discussing in the pathogenesis. Now, host factors. So genetics, as I already told, alpha-1 antitrypsin deficiency, because in chromosome 14, and in alpha-1 antitrypsin deficiency, the most common is the PiZZ. The PiZZ phenotype is more prone to developing COPD. Then there is something called as the bone morphogenic protein, the deficiency of which can, or the mutate or the genetical alterations in which can cause COPD. Then there's basically a proteinase anti-proteinase imbalance. Airway hyperresponsiveness is one of the factors, but it's more common a factor in asthma than COPD, and persistent airflow imitation. So this is what is happening. So basically, as I told, there are direct and indirect factors which are resulting in COPD. So the direct factor is a cigarette smoke or the secondary smoking or occupational exposure, and you have genetical susceptibility. Now, when both of these contribute to factors, this activates many cells in our body. So basically, it activates the macrophages. The macrophages releases something called as a protein. That's basically because of the activated macrophages, there is a imbalance between the proteinase and the anti-proteinase. So there will be overactivity of the proteases because of because the anti-protease deficiencies can occur. So because of this, there will be extracellular matrix destruction. Then there is neutrophil activation. And as we all know, neutrophil is one of the main source of the oxidants, antioxidants, free radicals. So all these will release mediators like NF-kappa beta or SOD3 and HDAC, or the histone deacetylase 2, which result in chronic inflammation. Then cigarette smoke, as we all know, it can cause defect in the epithelial cells or destruction of the epithelial cells, which can result in apoptosis and cell death. And another thing is lymphocytes, which can get activated, which is at a later stage. But the main pathogenesis is between the macrophages and the neutrophils and the epithelial cells. So always remember, while noting down the pathogenesis of COPD, take into consideration the macrophages, the neutrophils, and the epithelial cells. So If someone asks you what are the most common cells or the most common WBC cells which are involved in COPD, always remember, always talk about macrophages, neutrophils, and epithelial cells. And in macrophages, the protease, anti-protease deficiencies. In neutrophils, the oxidant and antioxidant imbalance. In epithelial cells, about the apoptosis. And in lymphocytes, the lung repair, the defective lung repair. And there is TGF beta, which causes which is more of a fibrotic, which is profibrotic. So pathophysiology, as we already discussed, there is airflow limitation. There's a persistent airflow limitation. There's low FEV1 by FEVC. There's low FEV1, and as we already saw, the trend in decrease in FEV1, and there's an increased residual volume and total lung capacity. Airflow limitation, it is persistent. It is not reversible, but there are recent studies which have shown that it might be reversible. And there's loss of elastic recoil of the lung, which I'll be describing in a, this is the picture which I'll be describing it in. So this is your normal lung. All right. So here you have the alveoli, here you have the airways. So the airway is connected to the alveoli with so many connections. These are elastin or the matrix connections, which connects the alveoli, which connects your alveoli to the airway. And this is the elastic recoil of the support, which is giving support to your airway. So basically, this is holding your airways, the blue lines or the blue arrows, which you are seeing. As we see, there's an outward force, and this outward force is keeping the airway at a what do you say, at its normal position, or it's normal, it's keeping the airway expanded, or it is maintaining the balance or the elasticity of the airway. Elasticity is the wrong term to use, or the balance of the airways, or the opening up of the airways. But what happens in COPD or emphysema, because of the protease anti-protease imbalance, the proteases gets activated, and all these extracellular matrix proteins or the connections which are there are gone. So the balance structure, the structures which balance the airway in an open or in the open state is gone. So there's an imbalance in the airway balance, and therefore there is airway wall destruction. So this is what happens. So this is what the elastic recoil is gone. The airway cannot open up complete. The walls of the airway get destroyed. So this in turn leads to air trapping. Then second is the end. So the first pathophysiology, as I told, is airflow limitation. Why does the airflow limitation occur? Because the basic supporting framework of the alveoli is destroyed. There is destruction because of protease, anti-protease deficiency. There is destruction of the elastin fibers, and due to that, there will be destruction of the airway walls. Then there's a ventilation perfusion mismatch. Now, what does ventilation perfusion mismatch means? As we all know, for a normal oxygenation cycle, or the body to get normal oxygen or normal transportation of the oxygen, should be a balance between your ventilation, that is your oxygen or the air that is coming in, and perfusion. Perfusion is basically the blood that is coming in for the capillary, from the capillaries for the oxygenation to occur. Now, what happens in COPD is there's a ventilation and perfusion mismatch. This results in pink puffers and blue blotters. And as we, from the term itself, we can see it's blue blotter. What does blue mean? Blue is due to cyanosis. And cyanosis causes, and cyanosis means, which means that there is reduced hemoglobin, there is reduced blood supply. So that means there is reduced ventilation. So areas of good perfusion and poor ventilation causes blue blotters, that is chronic bronchitis, and poor perfusion and good ventilation causes an emphysema predominant phenotype. So this is what happens. So here you see this is a blue blotter. As we say, it's blue due to cyanosis, and this is a pink puffer. Now, what happens in a blue blotter? In a chronic bronchitis, you have chronic productive cough, you have purulent sputum, you have hemoptysis, you have mild dyspnea initially, cyanosis due to hypoxemia. Why does hypoxemia occur? Due to poor ventilation. So because of poor ventilation, because your airway, because of all the inflammation that is occurring, your airway wall is narrowed. And whenever the airway wall is narrowed, the amount of oxygen getting in will be reduced. So the thing is, you are getting good perfusion, but you are not getting enough of oxygenation. So that results in cyanosis. There will be peripheral edema. So this leads to cor pulmonale. When your body is persistent in hypoxemia, or persistently whenever there is a decreased oxygen, there will be right AV dilatation, which leads to cor pulmonale. There will be clactals and wheezes, prolonged expiration, obese. And and the complications is it can lead to a secondary polycythemia, because why does a secondary polycythemia occurs? Because there is decreased oxygenation, the perfusion is impaired. So because of the ventilation perfusion mismatch, in order to compensate for your lack of oxygen, your hemoglobin, basically this is the oxygen dissociation curve, right? So because of that, to balance for the decrease in oxygenation, there's a secondary polycythemia vera occur, pulmonary hypertension, and core pulmonary from chronic hypertension. And in pink puffer, this is a classic COPD patient. This is what we call as a chronic COPD patient. The patient has a lean, thin framework. He has a pursed lip breathing, and he has complaints of dyspnea, minimal cough. And why he has a pursed lip breathing? Why is there an increased minute ventilation? Because there's an increased carbon dioxide because of the air trapping. This increased carbon dioxide causes increased respiratory drive, which results in an increased minute ventilation. There's a pink skin, pursed lip breathing. There's use of accessory muscles of respiration. There is cachexia. There's a hyperinflation. There is barrel-shaped chest, decreased breath sounds, and complication because they are more prone to bulle, which I'll be discussing later. There is always a chance of the bulle bursting, and there's weight loss due to work of breathing. So now, when you come to another important pathogenesis which occurs in COPD, as we all know, as I told, there's something called as dynamic hyperinflation which occurs because there is a circular airway which we saw here. And when the airway support is lost, you know the airway is in an open state. It doesn't have any airway walls. Now what happens here is the air gets in during inspiration. It gets trapped. And this trapped air doesn't escape. It keeps being there. And this is known as air trapping because during expiration, since the alveolar wall, your airway doesn't have enough support and tethering to the alveoli, the airway doesn't collapse during expiration. Therefore, a lot amount of air gets trapped inside your airway. So here you see, initially this is normal. After the onset of COPD, air becomes progressively trapped in the lung during periods of rest. So that's what I told. After some point of time, because the support is lost. So basically, you see a rubber band. You need a force to open up the rubber band, and you need a force to, when you leave the force, the rubber band comes back to the normal position, right? So in the same way, because of the support that is given by the framework here, this is what keeps the alveoli open, and during expiration it closes. Now, because the support of the tethering framework is lost, the air doesn't completely, the air cannot be completely expired out. So this results in air trapping. After that, this trapped air decreases both the inspiratory and the expiratory residual volume, resulting in a static hyperinflation. That is, there's air trapping at rest. Then during physical activity, what happens? During physical activity, you need more of oxygen. You are respirating at a higher rate. Therefore, the amount of washout, the amount of air that goes out becomes even more lesser. So this is how it progresses. Initially, you have normal, then you progress into a state of static hyperinflation. That is only at rest, there is air trapping. Then in dynamic hyperinflation, that is during physical activity, even more air becomes trapped, and this leads to breathlessness. So this is what happens. If you have air trapping at rest, it doesn't create a problem. So this is why you call it as a progressive disease, right? Initially, you have only on exercise, then later it becomes at rest. So then what are this is another important question which is normally asked. What are the changes in the diaphragm in COPD? So there is the decreased zone of apposition. There is shortening of the muscle fiber and increased radius of curvature. Basically, your diaphragm gets pushed downwards, right? Because of the hyperinflation that occurs in the chest, your diaphragm gets pushed downwards. So because of this, there's a shortening of the muscle fiber. There's an increased radius of curvature, and there's a decreased zone of apposition. So all these are, remember these three things. These are the three classic things which occurs in the diaphragm. That is, there's a flattened diaphragm. That is more of an X-ray finding. You have shortened diaphragmatic muscle fibers. You have increase in radius of curvature of the diaphragm muscle fibers. And there's a decrease of zone of apposition between the diaphragm and your rib cage. So this is another important figure which shows the pathogenesis. So here you have your disrupted alveolar attachments. So these are the which were the attachments which were there. These are the normal attachments. Normal attachment. See, this here you have a intact alveolar attachment. Here the airway and your interalveolar attachment are intact. Here what happens? Your airway attachments are gone. So this is a microscopic view of the diagram I was showing you at first. So here you have a disrupted alveolar attachments which occur. You have lymphoid follicles in severe diseases like infection, that is lymphocytes which we saw. which causes a defect in repair, which causes a defect in transforming growth factor beta. And you have inflammatories, macrophages, your neutrophils, and your CD4 and CD8 plus cells. So basically, you have cigarette smoking and risk factors, oxidant antioxidant imbalance due to neutrophils. Then you have the activated macrophages, which causes the protease anti-protease imbalance, extracellular matrix destruction. So the proteases are overactive. So this results in emphysema. Because of the airway hyperresponsiveness, there is increased mucus secretion, which results in chronic bronchitis. And all of this in turn will contribute to COPD. That is, airway hyperresponsiveness and smooth muscle hypertrophy results in chronic bronchitis. And your airway wall destruction results in emphysema. So this is the pathogenesis of COPD. As we know, there's a genetic predisposition, there is environmental factors, and there is risk factors. There is inflammation because of smoking, because from the neutrophil, there is release of neutrophil elastase and matrix metalloproteases. So these are the proteinases, and it degrades elastin by proteolysis. There is destruction of the alveolar wall and capillaries. There is enlarged air spaces or air trapping, impaired gas diffusion or ventilation perfusion mismatch, and there's an air trapping or expiration, that is dynamic hyperinflation. As I showed the progress, there is initially static, then it goes to dynamic hyperinflation, there is severe air trapping. Then there is also recruitment of your neutrophils and macrophages. There's increased oxidative stress, fibrosis and thickening of walls, narrowing of the airways leading to chronic bronchitis, and your goblet cell hyperplasia, which also result in chronic bronchitis. So basically, there is a protein antiproteinase deficiency. That is, there is antiproteinase is reduced and your proteinase is increased. There's aging and senescence, because the aging of the lung also contributes to a decline in FEV1. Mucus hypersecretion, which is more of a pathogenesis in chronic bronchitis. There's an oxidant and antioxidant imbalance. So these are the proteinases and the antiproteinases. So just remember, proteinases are the one which destroys your proteins. That is, some of the proteinases are neutrophil elastase, proteinase 3, cathepsin G, MMP1, MMP9, MMP12, cathepsin L, and cathepsin S. So cathepsin G, cathepsin L, cathepsin S, matrix metalloproteinases 1, 9, and 12, neutrophil elastase, proteinase 3, and cathepsin G. It's no need to by heart all this. Only if you're preparing for entrance, rarely it can be used as an MCQ. And these are the antiproteinases. Remember, alpha-1 antitrypsin deficiency. As we all know, alpha-1 antitrypsin deficiency. That is, when alpha-1 antitrypsin, all these are antiproteinases. So alpha-1 antitrypsin, always remember, it inhibits serine proteinases. So whenever there's a deficiency, there is overactivity of the serine proteinases, which results in airway extracellular matrix destruction, alveolar wall destruction, resulting in COPD. And alpha-1 antitrypsin always arises from the hepatocyte. So remember, alpha-1 antitrypsin, alpha-2 macroglobulin, TIMPs, SLPI, elafin, and cystatin C. Now, alpha-1 antitrypsin deficiency, as we all know, is one of the most common genetic factors which is there. It most commonly involves a chromosome number 14. PIZZ is the one which causes severe deficiency of alpha-1 antitrypsin deficiency. PIMM doesn't cause much of an alpha-1 antitrypsin deficiency. Another important factor to notice, if the alpha-1 antitrypsin levels are less than 11 micro, just cross-check it, I think it's 11 micromoles per liter, you need alpha-1 antitrypsin augmentation therapy. So pathogenesis of COPD. So as we all know, the risk factors we have discussed, the pathogenesis we have discussed in a nutshell, then we have discussed the symptoms. Now, after a combination of all this, you go into a spirometry. So spirometry is required to establish the diagnosis of COPD. So what are the key indicators which help you in, while in history taking, what are the factors which help you in considering a diagnosis of COPD? Firstly, there's a dyspnea. Dyspnea that is progressive over time. Unlike in asthma, when the dyspnea occurs only in short bursts whenever he is in exacerbation, it characteristically worsens with exercise and it's persistent. Then there's a chronic cough, which may be there's a chronic cough which may be intermittent and may be unproductive. There's a recurrent wheeze which occurs. Then there's a chronic sputum production. So all these are factors which help you in differentiating it from asthma. In asthma, as I told, only in exacerbation there will be worsening of symptoms. Then obviously in family history and personal history, you'll have history of risk factors, history of tobacco smoking, smoke from home cooking and heating fuels, occupational dust, vapors, gases and other chemicals, and family history. Just ask about is what do you say, the antenatal, prenatal, postnatal history as well. Mother had any history of smoking or not. If there's a low birth weight or there's a chance of childhood respiratory infections that occurred, and key factor here is always consider COPD and purpose spirometry if any of these indicate an individual over 40. So earlier we used to say, always say that COPD is always a case in which you say the diagnosis is always above an age of 40 years. But in recent times, the diagnosis, you, excuse me, the diagnosis, now there are factors like pre-COPD and all that, or COPD in young, which can occur less than 40 years. But for in majority of the cases of COPD occur in individual more than 40 years of age. One second. Okay. So history taking, dyspnea progressive over time, cough mainly with expectoration. There's a chronic sputum production. The patient has the recurrent respiratory tract infections. So history taking, we have already discussed. This is just a nutshell. Nothing much to be this thing. Whether he had any history of exacerbation or previous hospitalization, whether he had any presence of comorbidities. That is to see whether the comorbidities in turn is contributing to the worsening of COPD, because there are a lot of comorbidities that can occur in a patient with COPD, way more than asthma. Then this is something which you always take history, whether he has any psychosocial issues, depression, economic impact, feeling of depression, anxiety, well-being, and sexual activity. So that's it. Now, examination, polycythemia. Firstly, you start from conjunctiva, you get polycythemia, which is a sign of chronic bronchitis. Cyanosis, blue blotter, chronic bronchitis. Barrel-shaped chest. How do you define a barrel-shaped chest? Your AP diameter is to transverse diameter. Usually, your transverse to AP diameter is 7 is to 5. Here, your AP diameter is more than your transverse diameter. Many times it is equal to 1 or more than 1. There will be use of axillary muscles of respiration, because he has in severe emphysema cases, patient will have a pursed lip breathing. There's something called as a forced respiratory time, expiratory time, which is one of the, if you go through your books, it's one of the clinical examination finding. Hyperresonant note, more of a subjective finding. There may be rhonchi and crepitations. Crepitations can be normally present in a patient of COPD due to rapid closing and opening of the airways which occurs. So this is a spirometry. This is a normal trace. This is your volume time graph in which you forcefully expire for a period of 6 seconds. This is a normal curve in which your, and this gives you the slope. In here, your FEV1 is 4 liter, FVC is 5 liter, FEV1 by FVC is 0.8. But here, if you see in obstruction, you see the FEV1 is drastically reduced, your FVC is reduced, and as a result, your FEV1 by FVC is reduced. So depending on your FEV1 reduction, your COPD can be divided into mild, moderate, severe, and very severe. And it's based on your FEV1 value. Mild is if the, and all these after the patient has been established to have an FEV1 by FVC less than 0.8. And based on the, and these FEV1 values, whichever you are taking, are the post bronchodilator FEV1. In this, you have mild, moderate, severe, and very severe. Mild if your FEV1 is more than 70%. Moderate if the FEV1 is between 50 to 80. Severe or 50 to 79. Severe between 30 to 49. And very severe less than 30% per day. So just remember this. The similar way, there's a classification in asthma as well to classify the severity of bronchial asthma. So then you have the modified MMRC dyspnea scale, which is used for the symptom assessment. Here you have assessment of COPD. This is basically a spirometry, which is a, what do you say, a diagnostic testing finding. This is more of your symptom assessment. Here you have MMRC grade 0, 1, 2, 3, and 4. MMRC grade 0, he has breathlessness only in strenuous exercise. Grade 1, patient walks uphill, he feels breathless. Grade 2, he walks slower than his peers on a level ground, or he finds two breath because of or had to stop for breath when waking at his own pace. MMRC grade 3, after 100 meters, the patient has to stop for breath or few minutes on level ground. MMRC grade 4, I am too breathless to leave the house, or I am breathless when dressing or undressing. So this is one thing which can be used for symptom assessment in COPD. Then this is something called as the COPD assessment test or the CAT score. So this is a scoring of around all these questions. That is 1, 2, 3, 4, 5, 6, 7, 8. And each of this have a point of 5. And this is how you classify. It's basically like your pain scale. And here you have, I never cough, I cough all the time. So depending on that, you have to you have to make a scoring. And in later when you come into the, when we come into the treatment part, we will come to know about the importance of this CAT assessment which is there. So just for a minute, go through the CAT assessment score. So this is where it's useful. So this is known as the ABCD assessment tool. So initially, if you have a patient with COPD, you have taken the history, you got all the symptoms of cough, breathlessness, recurrent respiratory tract infections, smoking history, environmental tobacco smoke history, air pollution history. So you have spirometrically confirmed the diagnosis of COPD. That is, FEV1 post bronchodilator, FEV1 by FVC is less than 0.7. So after that, as we know, the pros bronchodilator FEV1, you do a gold assessment, that is greater than or equal to 80, 50 to 79, then that's it. So which I have already discussed. The next step is we used to see the CAT score. So CAT score, as I told, and the MMRC score. So here you have something called as a, this is like a square which has been divided into 4. And always keep in mind this square which is there, because this is the basic mainstay of treatment which you need in COPD cases. So here you have A, B, C, and D. A is MMRC is 0 to 1, or your MMRC grading. B is MMRC, and the second point in x-axis is MMRC greater than or equal to 2. CAT is less than 10. CAT is greater than or equal to 10. Then you have something on the y-axis. One is 0 or 1, not hospital, not leading to, that is, this is exacerbation history. So if the patient had only 0 or 1 exacerbation, but it has in the past 1 year, but it has not led into any admission, that comes under this thing. The second point on y-axis is if he had at least 1 exacerbation which required admission, or greater than or equal to 2 exacerbation. So here it's greater than or equal to 2 exacerbation, but it never resulted in admission. Here you are greater than or equal to 1 leading to hospital admission. So depending on that, depending on the ABCD assessment tool, you can divide the COPD into A, B, C, and D. So in A, you have MMRC grade 0 to 1, MMRC greater than or equal to 2, CAT less than 10, CAT score greater than or equal to 10. And depending on this, you can divide the cases of COPD. And this helps you in treatment as well as the assessment of risk factors for exacerbation. So these are the differential diagnosis. COPD, as you know, asthma, as I told, it varies in time, and it varies in intensity over time. It occurs early in life. There will be history of allergy, asthma, everything, history of allergic rhinitis, allergic conjunctivitis, etc. Congestive heart failure, there will be features of congestive heart failure. There will be bilateral pitting, pedal edema, congestive hepatomegaly, ascites, raised JVP, RV, the R3 gallop sound, which is heard. Bronchiectasis is more of a purulent expectoration, and they will have a much, much larger volume of expectoration than COPD, and it's commonly associated with bacterial infection. And you keep having cycles of bacterial infection. Tuberculosis, it can occur at all ages, and cough greater than 2 weeks, you can get a cavity on extra. You'll have systemic symptoms like this: weight loss, night sweats, evening rise of temperature, contact with a TB patient. You might be immunocompromised due to HIV. Obliterative bronchiolitis, it occurs at a younger age. It's a respiratory bronchiolitis. The patient may have a history of rheumatoid arthritis or acute fume exposure. It can be seen after or a bronchiolitic obliterant syndrome or obliterating bronchiolitis. It can be seen after a lung or a bone marrow transplantation. And a CT on expiration shows hypodense areas. Then there's something called as diffuse pan bronchiolitis, which occurs in Asian descendant. They're male non-smokers and it's mostly associated with chronic sinusitis. So always remember differential diagnosis of COPD is bronchial asthma, bronchiectasis, tuberculosis, obliterative bronchiolitis, and diffuse spam bronchial, because all of them are involving the airway. So next we come to management of COPD. So here we have discussed the pathogenesis of COPD, the main symptoms of COPD, what are the assessment scores, your CAT score, your MMRC, dyspnea grading, then the ABCD assessment tools in which you divided the COPD into 4, A, B, and C, and D, and this helps in the management of COPD. So there are mainly two principles in management of COPD. Manage the current condition of the patient, that is the symptom control, and always also prevent the further exacerbations from occurring, and treat the comorbidities which are there. So the main principle of COPD is smoking cessation is the key in controlling COPD. E-cigarettes as a smoking cessation aid, the use is uncertain. Then vaccinations, which are a key part of COPD. And then you have pulmonary rehabilitation. So this is just for knowledge sake. What are the steps in smoking cessation? Always ask, assess, ask, as advise, assess, assist, and arrange for follow-up. Self-explanatory term. Ask the patient why he is smoking. Identify all the patients. Advise him to stop smoking. Assess what is his willingness to quit. Assist him, aid the patient in quitting, and arrange for follow-up. What are the various things? There is nicotine patches, nicotine lozenges, nicotine gums, nicotine sprays, drugs like bupropion, varenicline, and nortriptyline. This topic, I won't be going in much detail in this because this in itself is a different topic or a different point in study. So next, as we told, smoking cessation. So firstly, I'll be talking about what are supporting measures which are needed, and then we'll go into core treatment of COPD and COPD exacerbation. Next is vaccinations for stable COPD. As we all know, there are mostly 3 common vaccines: pneumococcal vaccine, influenza vaccine, and the Tdap vaccine, or the typhoid and diphtheria vaccine. So influenza vaccine is reduces serious illness. Then COVID vaccine, as we all know, because the COPD patient already has a compromised lung function. If he gets a pneumonia, that will be a problem. Third is the pneumococcal polysaccharide vaccine. So the PPSV23 or the 23, there are two actually. The one is PCV13 and the other is PPSV23. So the PPSV23 has shown to reduce the incidence of community-acquired pneumonia in COPD patients aged less than 65 with an FEV1 less than 40% predicted, and in those with comorbidities. Age less than 65, FEV1 less than 40, and in those with comorbidities, always give PPSV23. So this is all from GOLD guidelines. And when do you give PCV13 or the 13-valent conjugated pneumococcal vaccine? Age greater than 65 years. Same, it prevents invasive pneumococcal vaccine. So age less than 65 years with comorbidities and what do you say? If even less than 40% predicted, use a 23-valent pneumococcal polysaccharide vaccine. If the age is greater than or 65 years, always use a PCV13, and it has demonstrated significant efficacy in reducing bacteremia and serious invasive pneumococcal disease. And the CDC recommends Tdap vaccination to protect against pertussis who are not vaccinated adults, and zoster vaccine. Now the pneumococcal vaccine, as we have already seen, PPSV23, PCV13. PCV13 has to be used in greater than 65 years. PPSV13 less than 65 with comorbidity with FEV1 less than 40%. Now we come to the management per se. So what is the mainstay of management? As I told in the class of asthma, the mainstay of treatment there was inhaled corticosteroid and inhaled corticosteroid combination with a long-acting beta agonist. In stable COPD, the mainstay of management is a bronchodilator, but steroids do not have any use. I will talk about that in the coming slides. What is the use of steroids? So you have a long-acting beta agonist, long-acting muscarinic agonist, query inhaled corticosteroid. I put a query in inhaled corticosteroids because we'll see. So these are examples, or this is something which you already know. Examples of some long-acting beta agonists: phenoterol, phenabitrol, salbutamol, terbutaline. These are all short acting. That is the most common here is levosalbutamol, salbutamol or albuterol or terbutaline. And long acting, you have phenoterol, formoterol. You have the formoterol, R-formoterol, indacaterol, which is the ultra long acting, and olodacaterol. Anticholinergic, you have the short acting ipratropium bromide, which acts for a period of 6 to 8 hours. Then you have the long acting, which is tiotropium, which acts for about 24 hours, and the ultra lama, which acts for about 12 to 24 hours, like glycopyrrolate, bromide. And then you have the combination, that is you have a combination of sama, that is phenoterol with ipratropium or salbutamol with ipratropium. Then you have a lama in a single device, formoterol glycopyrronium, indacaterol glycopyrronium, bilantrol umeclidinium, and olidocaterol tripyrronium. Then you have the methylxanthines. Then you have the combination of steroids. So basically, and there's a triple regimen. Now I'll discuss in the coming slide where to use what. Now methylxanthines, as we all know, acibrophylline, deriphyllin, doxophylline are one of the most common drugs which we use in OPD practice. Already during my asthma class, I told that they have no role in asthma according to the GINA guidelines. Now in COPD, already in earlier in COPD cases, methylxanthines were never found to have any role according to gold guidelines, and they were against using methylxanthines only and against using methylxanthines. But according to the current guidelines, now they have approved methylxanthines for treatment in stable COPD. So there's evidence for a modest bronchodilator effect compared with placebo in a stable COPD. Addition of theophylline to salmeterol, fluticasone, so salmeterol is a long year term, produces a greater improvement in FEV and breathlessness than salmeterol alone. A study investigated the effectiveness of adding low-dose theophylline to ICS in COPD patients at the increased risk of exacerbation showed no difference with placebo in number of COPD exacerbations. Or only thing to remember here is the patient has any other cardiac abnormalities, or if the patient has any other comorbidity, hypertension, heart diseases, always be careful while giving methylxanthines because it has a very narrow therapeutic index. And if you look at the risk benefit ratio, there's not much of a benefit giving a methylxanthine. So bronchodilators, inhaled bronchodilators are the mainstay. Regular and alternative use of SABA or SAMA improves the FEV1 and symptom. Combination of SABA and SAMA are superior compared to either medication alone. LAMA and LABA significantly improve your lung function, dyspnea. And among the LAMA and LABA, that is between a long-acting beta agonist and long-acting muscarinic antagonist, your long-acting muscarinic antagonist is always more useful than your long-acting beta agonist. And a combination therapy is always useful. It increases FEV1 and reduces symptoms compared to a monotherapy. Now, tiotrope improves the effectiveness of pulmonary rehabilitation, increasing exercise performance. Theophylline exerts a small bronchodilator effect in stable COPD patient, and it has a modest symptomatic benefit. So anti-inflammatory inhaled corticosteroid can be used only in group D type of COPD patients. It increases the risk of pneumonia, especially in those with severe diseases. Triple therapy, I'll be discussing when to give. Oral corticosteroid, short course of up to 5 to 7 days can be given in time of exacerbation, but long-term no use is a strict no. And there's no evidence of benefit. PD of E4 inhibitor like your roflumilast, it has a improves lung function and reduce moderate and severe exacerbation. A PDE4 inhibitor improves lung function and decrease exacerbations in patients who are on a fixed dose LABA ICS combination. Antibiotics, long-term azithromycin and erythromycin reduces exacerbation over 1 year. Treatment with azithromycin is associated with increased bacterial resistance. Resistance. A mucoregulator, your N-acetylcysteine, it reduces the risk of exacerbation only in select population. So, factor, then when do you give? As we already told, we had a discussion about inhaled corticosteroid. Now the question is, when do you give a inhaled corticosteroid? Factors when to initiate an inhaled corticosteroid treatment. So strong support, if the patient is group D, that is he has history of hospitalization for exacerbation greater than or equal to 2 moderate exacerbation of COPD per year, blood eosinophil greater than or equal to 300, history of asthma. Consider use if he has 1 moderate exacerbation, out of the blood eosinophil is between 100 to 300. And when not to use, repeated pneumonia, blood eosinophil less than 100, infection, or if he had a history of TB. So always remember that. So withdrawal of ICS, a study examining ICS and dual bronchodilator demonstrated both FEV1 loss and increased exacerbation frequency associated with ICS withdrawal was the greatest among patients with a blood eosinophil count greater than or equal to 300 at the baseline. So that's more of an academic interest. So other, as I told, if it's an emphysema, there's alpha-1 intravenous augmentation therapy with alpha-1 antitrypsin, antitussives, vasodilators. Do not improve outcome, may worsen oxygenation. Antitussives, no conclusive effect, just as a supportive management you can give. Palliative care like opiates, your opioids, neural, muscular, nerve, electrical stimulation. Fan blowing on the face can relieve breathlessness. In malnourished patient, nutritional supplementation may improve respiratory muscle strength or overall health status. Fatigue can be improved by self-management education, pulmonary rehabilitation, nutritional support, and mind-body interventions. So oxygen therapy and ventilatory support in stable COPD patient. Long-term administration of oxygen increases survival in patient with chronic resting hypoxemia. And ventilatory support only at a later date. If he has a severe exacerbation, if he has continuous CO2 retention and all that, only then you need to give a ventilatory support. So oxygenation support, it improves the resting arterial hypoxemia and it increases patient survival in patients, basically. Intervention therapy, just remember the names, that is enough. For a UG level, lung volume reduction surgery, bulectomy, transplantation, bronchoscopic intervention. So all these are a class in itself. What are the interventional therapies which you can start in stable COPD patients? So basically, this is what is there. So as we all know, the ABCD in A, that is, you can use a bronchodilator, a SABA or SAMA SOS. If it's group B, you have a long-acting bronchodilator, that you have a LABA or a LAMA. Then in group C, you always have a LAMA. And in group D, you have a LAMA or a LAMA plus LABA or ICS LABA. So basically, it's a step up. If he is put on a LAMA, not improving, put a LAMA or LABA. Consider a LAMA plus LABA only if he's highly symptomatic. That is, the CAT score is greater than 20. Or consider an ICS LABA, as I told earlier, if the eosinophil count is greater than or equal to 300. If he has 2 or more moderate exacerbation, 1 exacerbation requiring admission, and when not use inhaled corticosteroid, when he has less than 1 moderate exacerbation, he had past history of tuberculosis, or if he had recurrent pneumonias. So this is what basically you have dyspnea. You start the patient at LABA or LAMA, not improving, put a LABA plus LAMA combination. Consider switching inhaler device or molecule. So investigate further options of dyspnea. If the patient is on LABA, LAMA, ICS and still not improving, go for checking the inhaler technique and investigate further causes. And if it's a LABA plus ICS, always add LAMA plus LABA. So, and exacerbation. If the patient has exacerbation, depending on that, you have to take the treatment. And in LAMA plus LABA plus ICS, if your FEV1, that is in group D, if your FEV1 is less than 50%, and if the patient is a chronic bronchitis patient, you can start roflumilast. And if the patient is in a former smoker, you can give azithromycin, cyclical azithromycin therapy. So basically, so if the patient is presenting in an exacerbation, he is using a LAMA or LABA, that was what he was using. Step up to a LAMA plus LABA. I can't use the word step up because it's more of a term which is used in asthma. So if you are using LABA or LAMA, add a LAMA to that. So if you use LABA, add a LAMA. If it's a LAMA, add a LABA. Then otherwise, you can ask inhaled corticosteroids depending on the above indications which I told in the previous slide. After, the important point to note here is this is the only area where you have a step down in asthma therapy. That is from LABA plus ICS. You can always remove the ICS and have a step down to either a LABA LAMA or just a LABA or LAMA alone. And even after giving a LAMA LABA ICS, if the patient is not improving, if his FEV1 is less than 50 and it's a case of chronic bronchitis, you can start roflumilast. If he's a former smoker, you can have azithromycin. And dyspnea. So this is what is in exacerbation. In dyspnea also, there is no point of adding an ICS, only in a later stage. So LAMA and LABA are always preferred. A long-acting beta agonist and long-acting muscarinic antagonist are always preferred. Are preferred more than a short-acting agent. And patient may be started on a single or dual bronchodilator therapy. In patient with persistent dyspnea on one bronchodilator therapy, escalate it to a two bronchodilator therapy. Inhaled bronchodilators always prefer over bronchodilator. Don't keep on giving him tabs salbutamol. It doesn't help. Theophylline is not recommended until long-term bronchodilators are unavailable or unavoidable. Other interventions which can be done: pulmonary rehabilitation, exercise training, vaccination, nutritional support, always a high fat or a high fat plus a low carbohydrate diet to decrease the CO2 production, psychosocial support, and surgery. As I told, these are some of the surgery, that is the lung volume reduction surgery, enterobrochan valves and coils. Now, treatment of COPD exacerbation. Now, we have seen the basic outline. How do you treat a stable COPD patient? Now, we go into a treatment of COPD exacerbations. So, what do you mean by exacerbation? Exacerbation is defined as a worsening in the acute worsening of the respiratory symptoms. That is, it can be either a mild, moderate, or severe. Mild is treated with short-acting bronchodilators only. Moderate is treated with a short-acting bronchodilator plus an antibiotic or oral corticosteroid. Severe is one which the patient requires hospitalization or visits the emergency room. Severe exacerbation may also be associated with acute respiratory failure. So, it's mild, moderate, and severe exacerbation. In mild, you need only short-acting bronchodilator. Moderate, you need a short-acting bronchodilator plus an antibiotic or an oral corticosteroid. In severe, he requires hospitalization when he visits the emergency room. So, what are the main triggering factors? Viral infection, short-term air pollution, that is short-term exposure to fine particulate matter, that is PM 2.5, is associated with increased hospitalization for acute exacerbation. And the most common virus isolated is the human rhinovirus. And the most common cause of exacerbation in COPD is the virus. So potential indicators, you have to look at the physical signs of the patient, whether he's tachypneic, whether he's cyanosed, whether he has a toxic look, he has a very high RRE, whether he is drowsy, disoriented. All these are signs of CO2 narcosis, whether he is not obeying command, whether he has a low O2 saturation, use of axillary muscles or respiration. Then if he comes to casualty and you give a normal medicines, and if the patient doesn't improve, if the patient has serious comorbidities, insufficient home support and local support needs to be considered. So classification of hospitalized. So basically, as I told, there is mild, moderate, and severe exacerbation of COPD. Mild is one which is which can be treated with a short-acting bronchodilator. Moderate, you have a short-acting bronchodilator plus or an oral antibiotic or an oral corticosteroid. Severe is the one which requires admission. And in severe, you can be classification of hospitalized patient. You can divide it into no respiratory failure which is life-threatening, and respiratory failure which is non-life-threatening. So how can you classify this? So there are five main points which are there. One is the respiratory rate, other is the level of consciousness, third is the use of axillary muscles of respiration, fourth is hypoxia, and fifth is your partial pressure of carbon dioxide. Respiratory rate, if he has no respiratory failure, RR 20 to 30. Respiratory failure, life-threatening RR is greater than 30. Non-life-threatening RR is greater than 30. Consciousness, there is no change. Use of axillary muscles or respiration. This is jumbled up actually. So here your respiratory failure, this is non-life-threatening. And this is life-threatening. It's jumbled up. Sorry for the mistake. So here, so this is life-threatening. So when do you call it life-threatening? Whether when he has a this also is a change. He has a change in consciousness. He will have use of axillary muscles. Hypoxia, it improves only with the Venturi mask, which is the oxygen delivery device, greater than 40%, and his PCO2 is 50 to 60, and his pH is less than 7.25. That is, he is in type 2 respiratory failure. So I'll make the corrections when I'm sending the slides. This is jumbled up actually. So how can you differentiate non-respiratory failure as a normal RR? His hypoxia gets corrected with 24 to 35% oxygen. PCO2 is normal. As he goes into a life-threatening, his consciousness level gets altered. His PCO2 is elevated. His pH is less than 7.25. He has a use of axillary muscles of respiration. And hypoxia requires a larger amount of oxygen, that is more than 40% of oxygen is required. So how do you manage a case of severe but not life-threatening? And what is the difference? In life-threatening exacerbation, your pH is less than 7.25. You have a PCO2 which is 50 to 55, and your O2 requirement is more than 45% of FiO2. So here you had to bronchodilators had to be given. Consider oral steroid, short course of 5 to 7 days. Consider oral antibiotic. Consider NIV. NIV here, it's not for the type 2 respiratory failure. It's more to control the respiratory rate of the patient, and administer supplemental oxygen, obtain serial ABGs to see whether the patient is worsening. Then monitor fluid balance. If there is a patient is bedridden and you have a query of thromboembolism, you have some ECG changes, because COPD patients are always prone to atrial fibrillation or pulmonary embolism or multifocal atrial tachycardia. So consider subcutaneous heparin or low molecular weight heparin for thromboembolism prophylaxis. Identify and treat the associated condition. So key point of management of exacerbation: short-acting beta agonists with or without short-acting anticholinergics are recommended as the initial bronchodilator. If come to casualty, give that. Give a nebulization with Buolin, which is a combination of levosalbutamol plus ipratropium, or give a salbutamol nebulization. And systemic corticosteroid, that is your injection hydrocortisone, can improve your lung function, oxygenation, shorten recovery time. You can give a oral steroid also of not more than 5 to 7 days. Antibiotics if needed, and if you feel that there's infection, you can give. It also helps in decreasing the hospitalization duration. Methylxanthine is not at all recommended. Only recommendation of methylxanthine in stable in COPD is in case of a stable COPD patient. And non-invasive mechanical ventilation should be the first mode of ventilation used in COPD with acute respiratory failure who have no absolute contraindication, because it reduces the work of breathing, improves the gas exchange, and reduces the need for intubation, and decrease the hospitalization duration, and improves the survival in such patients. Then when do you admit the patient in ICU? If he has a severe dyspnea, that is not you treat him with casualty with all the above measures. He's not improving. He has a change. He's confused. He's drowsy. He's not obeying your commands. He has a pH of less than 7.25. His PCO2 is elevated. He needs a mechanical invasive ventilation. He has hemodynamic instability, or he needs vasopressors. So in such cases, you need a ICU admission. That means he's gone into a life-threatening exacerbation. So what are the indications of NIV? As I told, the indication of NIV can be in non-life-threatening or life-threatening. Why do you use it in non-life-threatening? To reduce the respiratory effort of the patient. And in life-threatening, to wash out the carbon dioxide. So at least one of the following should be there for you to use the mechanical ventilation. If the patient has respiratory acidosis, that is his PCO2 is greater than or equal to 45 mmHg, and his pH is less than or equal to 7.35. If he has a severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increased work of breathing, such as use of respiratory axaremasy, paradoxical motion of abdomen, or retraction of the intercostal spaces, persistent hypoxemia despite supplemental oxygen therapy. Then when do you use invasive mechanical ventilation? If the patient is completely drowsy, is non-responsive, or if he has a psychomotor agitation inadequately controlled by sedation, you need it. Status post-respiratory or cardiac arrest, massive aspiration or persistent vomiting, inability, if he is not able to bring out the secretions, if he is in hemodynamic instability, which is not improving, improving with your normal saline therapy or your normal resuscitation or vasopressor measures, if he has a severe ventricular or supraventricular arrhythmias, and life-threatening hypoxemia in patients unable to tolerate NIV. So discharge criteria, basically you see improvement in patient, you can discharge, and you have to give oral corticosteroids for a period of 5 to 7 days. Early follow-up less than 4 weeks, late follow-up less than 12 weeks. So reassess the initial inhalation technique. If he is smoker, advise him regarding smoking cessation. Then ask him to come after 1 to 4 weeks, roughly after a month. Reassess his inhaler technique. Reassess whether he needs oxygen. Do a CAT score and MMRC score. Determine his comorbidity. Do an ECG. Look at his body. Look at his body framework. Talk to him. See whether he has any psychogenic issues. And in 12 to 16 months, you had to do a further spirometry and stuff. So what are the most common comorbidities in COPD? I'll be just describing the names. Cardiovascular, yeah, he can go into a right heart failure, core pulmonary, chronic bronchitis, pulmonary hypertension, cardiac arrhythmia, atrial fibrillation, multifocal atrial tachycardia, lung cancer. So COPD patients, because they are smokers, they are always prone to lung cancer, developing lung cancer over a long period of time. So always consider a low dose screening CT in patients with COPD. Osteoporosis, depression and psychosocial factor, one of the most important factors, because it's a chronic disease, it's a comorbid condition, it is causing extreme disability to the patient. Proper counseling to the patient regarding his condition is necessary. Weight loss, GERD, which in turn can lead to exacerbation, more in interstitial lung disease, but certain studies have shown that it can also cause exacerbations in COPD and cognitive impairment. So that in a nutshell is my class on COPD. So just going through this. So basically, when you are going through the definition, persistent airflow limitation, it's a common preventable treatable condition caused due to airway or alveolar abnormality, usually caused by significant exposure to noxious particles or gases. Then we looked at the pathogenesis of COPD, in which you have direct and indirect factors. Then we looked at the different types of emphysema. Then we looked at the direct indirect factors. Then the Fletcher-Pato curve, which is most important, which shows the decline in FEV1. Then how cigarette smoking and what are the different inflammatory cells, what are the problems which they cause, which are the proteases, which are the antiproteases, what happens to the alveolar attachments, why does air trapping occur, what is the blue blotter, what is a pink puffer, how does a normal COPD progress from static to dynamic hyperinflammation, how does it causes air trapping. Then we saw what is the changes which occurs in the diaphragm. Then we went into which are the oxidants and the antioxidants, and the proteases and the antiproteases. Then we looked at what are the clinical symptoms in COPD, what are the differential diagnosis of COPD, what is the spirometry finding in COPD, then what are the assessment of COPD, how do you, then you are the ABCD tool, you are the MMRC score, the CAT assessment, your ABCD tool. Then what are the management of stable COPD, in which you saw the mainstay of statement is inhalers. Oral corticosteroids can be used only when there is exacerbations. Then smoking cessation, vaccination, age greater than 65, always give a PCV13. If less than 65, FEV1 less than 40 and comorbidities are present, always give a PPSP23. Then role of theophylline, which is only in stable COPD. And always a combination bronchodilator is better than a single bronchodilator. What are the other things which can be used? Oral glucocorticoids, no use. There's always a chance of emphysema. Then when to consider an ICS treatment in a case of COPD. Then when to withdraw ICS. And then we came into intervention therapy, just discuss the names. Then when we go into the ABCD tool, what are the treatments which can be used? What are the bronchodilators which can be used? Then we used the key point for the use of bronchodilator, what are the other interventions. And then we went into COPD exacerbations, the treatment of COPD exacerbations, in which you have the mild, moderate, and severe exacerbation. And in severe exacerbation, you have the life-threatening and the non-life-threatening ones. And whether life-threatening with respiratory failure, life-threatening with no respiratory failure. Uh, and then we see how to treat them, whether corticosteroids can be gone for a period of 5 to 7 days. If the patient is not improving in the initial therapy, always consider an NIV. If not improving on NIV, go for a intubation. Then we saw a brief description of the various comorbidities in COPD. So in a brief nutshell, I have tried to cover whatever is possible. COPD is a very, very vast topic. There's a lot more topics which are to be covered in COPD. And some of the points I would like to describe for further reading read about especially for PG students and exam going students, is to read about the various interventions in COPD, bronchoscopic interventions in COPD, what are the pulmonary rehabilitation which is applicable in COPD, what is the different exercise training, the strength training, the maintenance training, what are the useful of that, what is the mechanism of pursed lip breathing, Read alpha 1 antitrypsin deficiency in more detail. Read about asthma, COPD, overlap syndrome. Read more about PFT, the PFT patterns which are there in COPD patients. What is the risk of lung cancer in COPD? And read more about smoking cessation, more about the drugs which are used in smoking cessations, the various nicotine patches, nicotine lozenges, what is its effectivity, what are the dose in which you give them, what is the dosage of drugs which you start, because initially for 2 to 3 days you give it at a low dose, you gradually escalate the dose with bupropion or varenicline, what are the uses of transdermal patches. Then other topic of interest is up and coming topic is e-cigarettes. Then according to GOL 22 guidelines, there are COPD in young, pre-COPD. So read all these definitions as well.